are in listen-only mode.
Hi, everybody. Good afternoon for those of you on the East Coast, and good morning for those of you on the West and somewhere in between. So on behalf of Fight Colorectal Cancer, in a joint appointment with University of Colorado Cancer Center and the School of Public Health, I'm Andy Dwyer, and we're really excited to have you all join today for our webinar around colorectal cancer pain management. So we're very excited to have those experts joining us on the phone, who I consider experts as well, being Sharon Worrell, Michael Sola, as well as our Fight CRC, who's joining on in terms of helping all with the patient education and research aims throughout Fight CRC. So thank you so much, team, for supporting all the great work today. Today as our expert, we have Anna Navarro-Leahy, who's going to be joining us to speak about the pain management as our expert in the area of this subject matter. I'm very excited to have Dr. Navarro-Leahy joining us. Just a quick note that we really ask that during the course of the session that if you have any specific questions or thoughts, you go ahead and key those in. Over at the right side of your monitor, there's a way to key in questions, and Sharon will be doing the Q&A question for us at the end of the broadcast around the content. So please, anytime during the conversation, just go ahead and key those in, and Sharon will try to make sure to manage those so we have enough time for the question and answer. Follow us along on social media, #CRC webinar. And just a note, of course, that all of these webinars, including today's, will be saved at the Fight CRC website. And we do encourage all of you to share your perspective, thoughts on the content, satisfaction, as well as specific topics for us to address going forward. Next slide. Just a quick note, we've actually completely revamped the Guide in the Fight for a 3-part series that really speaks to the different stages and continuum of care for colorectal cancer and manageable sizes through 3 different specific formatted guides that actually complete the entire Guide in the Fight series, with one around treatment diagnosis, medical management, even thinking about logistical and end-of-life issues. So very excited about this new resource, and it's being downloaded with extreme excitement, enthusiasm, and I know that we're getting incredibly great feedback. So just a quick reminder, the Guide in the Fight lives on the website. It's a huge resource, and a huge thank you to Danielle, Andrew, and Sharon for all of their great work in formatting in this new format for Guide in the Fight, which continues to be a great resource. Just a quick note before we get started today, that of course all of the Fight CRC resources, webinars, as well as materials are to help supplement and provide education and support, but in no way replace the direct medical care. During today's webinar, we ask that you please speak about general questions that you might have about the content area, but if there are specific personal needs, make sure to please continue to contact your direct medical advisor, your care team, because we won't be able to actually take specific medical questions today on a personal individual basis. However, again, we love any sort of general questions you might have about the topic, but go ahead and continue to make that connection with your medical team. And of course, if anytime you're experiencing a medical emergency or feel that you might be in distress, 911 is the most prudent action. Next slide. And so with that, I'm going to turn it over to Dr. Anna Navarro-Leahy, who's joining us. She is part of the Denver Health Community and University of Colorado Health System here working in palliative care, and someone who works in the area of pain management. And he's really going to be speaking about the colorectal cancer components and maybe what are the treatments and specific conditions related to colorectal cancer, in really thinking about how to manage pain throughout the care throughout the time from diagnosis even through treatment. And we're really excited as she's had a lot of great experience in Chicago, and then also working in AmeriCorps on the west side of Chicago. So definitely a life that is contributed to service and educating folks. So Dr. Navarro, I think you are with us, and I will hand it over to you to begin.
Good morning and good afternoon to everyone. Welcome, and I really appreciate all of you for being able to join us today. First off, I just want to mention that I have no disclosures. I don't have any actual or potential conflicts of interest in relation to this presentation. So no financial support from companies, or I'm not a major shareholder in any company. So the goals and objectives of today are really to empower you and your loved ones. Today is meant to give you a glimpse of some of the things that may help you. So, please don't get bogged down with details. Just know that your medical providers have many, many tools in their toolbox to help you, and be assured that no matter what, they will be able to provide you with great care. So if you could all, depending on where you are, sit back, maybe even close your eyes, take a deep breath, and take a moment to think about what a good day for you is. Think of the kind of day that brings you joy, things that make you feel content. For everyone, this is likely very different. Some may envision a day spent with their family. Others may envision a quiet day curled on the couch with a good book. And someone else may envision, a nice stroll through the neighborhood. It may sound corny, but some people even write down those things that make a good day and keep it in their wallet or their purse, because this is really what we want to keep at the center of everything, because this is really what we're fighting for, making today the best day that it can be. So that being said, pain can certainly try and interfere with that goal. So today we're going to talk about pain management. So in order for your medical provider to really be able to help you best, they'll want to hear all about your pain. I'm sure many of you can recall being in the hospital or the doctor's office, and them asking you to rate your pain from 0 to 10. Usually they describe it as 0 is no pain, 10 is the absolute worst, you're in agony, you're ready to call 911 and have an ambulance show up. I think it's also reasonable for us to not let pain sort of be at the center of things and really consider that same rating scale, but think about, your ability to function. So 0 would be everything is normal, I'm living my normal life, nothing's interfering with it. And then you can consider the spectrum of 10, like the pain is so bad, I can't even get out of bed, I can't get up to go to the bathroom. And of course, there's lots of levels in between. Like maybe I can't go play the sport I normally do, but I'm still able to go to the grocery store and do some necessary errands. So rating your pain is part of how we describe it to medical providers. But we also just want to, describe it so that way the medical provider can better match what treatment would likely help you best. So some people might say it's dull, it's throbbing, it's cramping, I've got this numbness and tingling. And then, feel free just to describe it however you feel. I've had patients that told me, it feels like someone is wringing out my intestines, just like, you would wring out wet laundry. Other people might say, it feels like my feet are on fire. I just want to go jump in the snow. So it can be really helpful if you want to keep notes on your calendar, if there's certain times of day where it's better or worse, if there's certain activities or positions or foods that might make it better or worse. All this better helps your medical provider be able to help you. And then these descriptions that you provide really help your medical provider think through, what kind of pain do I think they're having? How do I best choose a medicine or treatment that really targets it more specifically and that I think we're going to be more successful with it? So, generally speaking, there's 3 major types of pain. You can think about the pain that you can point to. So if you break your arm, you're going to be pointing at the arm and say, it hurts right there. Versus maybe your whole abdomen hurts and there's not one part that you can point at. You're just sort of like, oh my goodness, it's just sort of all over this whole area. And then there's also nerve pain from different ways a nerve can be damaged. And that's often more of a numbness or tingling. And then when you describe it, it sort of matches a distribution that we would expect based on our anatomy. So something we want to ask about with every intervention offered, whether it's a medication, whether it's a procedure, whether it's an anti-cancer therapy, is really what are the benefits, risks, and burdens? Some people might say sort of what's the good, bad, and ugly about it. So we should always be asking, what do we hope to achieve with this? What are the good things about it? If we're talking about pain, what part of the pain do we think is going to get better? How much better do we think it might get? Similarly, when we're talking about an anti-cancer therapy, are we hoping that we're going to cure it and get rid of it altogether? Or are we hoping to shrink it so that maybe it helps with some of our symptoms, or maybe we'll get more time? And then risks are sort of the bad or dangerous things that could happen. If anyone's ever had even a simple office procedure, you might remember the consent form where they say all the scary things that, even though may be very unlikely and only happen 1% of the time, they'll mention, like bleeding, infection, or even death. So it's just knowing, what are the bad things that could happen with this. And then the burdens really talk about just how annoying or cumbersome is the treatment. So for medication, do I have to take it 5 times a day? Is it a huge horse pill? Are there other side effects of it that aren't really bad, but just more annoying? Like maybe I'll have a little diarrhea. And I also think, realistically, we have to think of the burden of finances, because who knows, is something covered by insurance, or what's my copay? Because, that does sort of affect our choices moving forward. So I think, as we look at possible treatments, we always want to weigh all these three things together to really see, does it really make sense for me or not? And is it going to help me get to that good day that we're striving for? And then we always want to take caution with everything. Your medical provider will know if you're having issues with your kidney function or your liver function, as this might change the medicine that they might try. It may also change the dosing they will use. Another thing that we always have to be mindful of is drug interactions. So whether it's a prescription medication, whether it's an anti-cancer therapy infusion, or any over-the-counter medicine, we really want to be making sure that we have open communication about all the things we're using to really ensure our safety and that we're not causing a problem, ourselves by combining things. Another smart question to ask, is there a medication that can really kill 2 birds with 1 stone? The more you can share other symptoms that are bothering you, we can try and choose therapies where their side effects really work in our favor. So, having trouble sleeping is a common symptom that many people complain about. So sometimes, if that's a problem affecting you, we may choose a medicine that if we take at bedtime, will have the bonus effect of also helping us sleep. So first, we're going to start off with an overview of sort of conventional medicine, and then we'll move into complementary and alternative medicine. And just so you know, some of the medicines we use regularly are considered off-label, meaning that the FDA has not given the A-OK that they are used for certain things, but trust that the things that I discussed today, we commonly use quite regularly in the medical community safely. So let's first start off with good old Tylenol. Often people sort of forget about Tylenol or think it's sort of weak, but I mean, Tylenol is a great pain medicine alone, and then often, sometimes down the road, further into our disease process, it really can help together with other pain medicines. Some people may only use it as needed. Sometimes we'll have to do it scheduled 3 times a day. The big caution is, current recommendations are that we don't take more than 3,000 milligrams in a day. So going back to the using caution, is some medicines have Tylenol in them, so we just need to be mindful because it can sort of sneak up on you how much Tylenol you're actually intaking in a day. And then, of course, people with liver failure should avoid Tylenol. And even if you're having some liver problems, many people still safely use Tylenol. It's just really paying attention to your overall dose that you take, throughout 24 hours. Now, probably one of my favorite classes of medications are the non-steroidal anti-inflammatory drugs. Inflammation plays such a huge role in pain, so these medicines can be, quite wonderful. From over-the-counter ibuprofen to some of the prescription ones, and there are so many different kinds. So your medical provider can really take into account you as a whole person to see which ones make the most sense. We need to be careful if we're on blood thinners. We might choose a different one of the anti-inflammatories if we know that someone has heart problems. Similarly, if someone has acid reflux or heartburn, any of those things don't mean that you can't take anti-inflammatories. It just means we might be a little bit more particular about which one we choose. And then corticosteroids are also very strong anti-inflammatories. And they work very, very well for when the cancer has spread to the bone and caused bone pain. They also help when the cancer has spread to the brain and we're getting some swelling and side effects from that. Again, this is a big thing where sometimes it makes sense in your treatment to use it, sometimes it doesn't. Oftentimes, if someone is on a clinical trial, you're not allowed to be on it, but it's definitely something, to ask. And we talked about, added bonus side effects is, they can give you daytime energy. So if we dose it where you either take it in the morning or in the morning and early afternoon, some people will have the added bonus of, energy if fatigue is a problem that's also plaguing them. So the bisphosphonates, you may have seen, commercials for this on television. These are traditionally used for people with osteoporosis. We use them when people have cancer that has spread to the bone. Again, there are many different kinds. Some are infusions, some are pills. They have different sort of scheduling that people can have them prescribed, but they work, really well. And then, we don't want to forget about topical agents. We really love topical agents because then we don't get the effects that affect our whole body, especially if there's only, a small or very specific place that's bothering you. So lidocaine is a numbing agent. It works really well for areas with nerve pain. Some people really like the gels, depending on when you have the pain and things that make it better or worse. Sometimes a patch is a little easier because you can leave it on for the 12 hours during the day. And I think also, when we're talking about topical agents, even early on, there's many over-the-counter topical agents that people feel help them depending on the pain that they're having. So it's not unreasonable to try any of them. So antispasmodics, there's a couple different classes, but really we use them for a few things, like the baclofen and the cyclobenzaprine really help with muscle spasms to really help relax the muscles. And again, depending on your other symptoms, it really helps your provider choose, which muscle relaxant would make the most sense for you. Some people also will have, spasms in the gut. So dicyclomine helps really well to relieve those. Antidepressants, so you can see that those are the three sort of main classes of antidepressants. And they work great for nerve pain. And like we had mentioned earlier, getting our 2-for-1, the tricyclic antidepressants, which are often first line for nerve pain, when we dose them and take them at bedtime, do help with sleep. Some of the other antidepressants have emerging data to not only help with nerve pain, but also musculoskeletal pain. So again, we really need to, make sure we're choosing the one that makes the most sense. Similarly, if people are also having depression or anxiety, that may help choose us, which one we should try first. And anticonvulsants, oftentimes when we prescribe these, patients don't realize that traditionally these were how these medicines initially came to be, and they might get concerned when they Google it. But they're very safe and they work great for nerve pain. We use them for lots of different things. Again, if people are having daily headaches, whether they're migraine, whether sort of post-traumatic headaches, these can also help prevent those headaches. So again, really trying to choose a medicine that will help more than one problem is great, because then that can really minimize the total number of medicines that you're taking. So let's talk about opioids. I know, especially right now with the media, whether you're opening the newspaper or turning on the news, I doubt you can really get by a week without hearing bad stories about opioids. But I really want everyone to rest assured that opioids are indicated for cancer pain. They work very, very well for cancer pain. And we know when we prescribe them appropriately, we do not have the risk of addiction. Because, your medical provider is really an expert in how to use opioids. So they will be able to match how much pain you have with the appropriate amount of medicine. Some patients tell me, I have a concern that I'm going to need more over time. And, that may be true, because over time, your disease could progress, your pain could progress, and you may require more opioid. There are many opioids, morphine, oxycodone, hydromorphone. And there's also many formulations. They come in oral pills, they come in oral solutions. There's short-acting opioids that last, roughly 4 hours. There are long-acting opioids that can last 12 hours. They can come in a patch. And then sometimes, even if someone's having really severe pain that's difficult to manage, some people even go home on IV patient-controlled analgesic pumps. So there's so many options. And one opioid isn't necessarily better than the other. We usually start with one, again, thinking about how your kidneys are working, how your liver are working, really what makes the most sense. And then know we can always switch to another if one is not working well. But doctors are very good at starting low, going slow, and making sure we're doing everything, in a safe process. And then as things progress, being able to safely increase it to match it. Again, our ultimate goal being to get to that good day. So we don't want to give too little where the pain's too severe and you can't, do your activities that you would like to do. But of course, we don't want to overdo it either. So we're always striving to find that sweet spot to really make sure we have the correct dose. But we know over time, we will likely have to alter that as disease progresses. So something I did not have in my original slides, but then I, pardon me, thought of last night is interventional therapies. So this is a little different for everyone, but especially when we're talking about colorectal cancers and, depending on where masses or tumors may be causing you pain, nerve blocks can be great things. So whether it's an interventional anesthesiologist who might do this procedure, sometimes it's a gastroenterologist who will do it in the outpatient suite. Sometimes it's done while someone's in the hospital, but there's various ways where they can do a nerve block, which is a great way to manage pain, because then you're not having to take medicine that affects the whole body. And again, this goes back to one of the earlier slides of really describing your pain, because your provider will be able to say, I have a hunch that a nerve block might make sense. Let's get that specialist on board and see if they agree with us, because this might be a great route to go to manage your pain. Similarly, radiation can be used depending on where cancer may have spread. And our radiation oncologists are great at looking at scans, hearing what you have to say about your pain, and really saying, I think this could really help. And sometimes they can really do it in just a couple sessions. Sometimes they'll just do one. They'll sort of work around what makes the most sense for you. But these are things to keep in mind, that there are other modalities that we don't necessarily go to as first line, but we're always thinking about, because if it's going to manage your pain, then we want to explore it. And then one thing that I also thought about this morning that is not on the slides is marijuana. So I practice in Colorado, where we have medical marijuana and recreational marijuana. Of course, a lot of that is changing all over the country. Like they had mentioned, originally from Chicago, who recently got medical marijuana, and now they are proposing laws to get recreational. Putting logistics aside, which is a little tricky because, my medical license is a federal license, so I don't, recommend and give people medical marijuana cards. But I have many patients who say, I want to explore this. So I think having open communication with your provider so that they know that you're looking into this, that's perfectly reasonable, and making sure that you're using a dispensary that seems reputable, because there are just so many different kinds, strains, mixes of the THC and CBD. I've had patients that have had success because, again, there's topical things, there's pills, there's oils. There's many ways to go. Unfortunately, we don't have great data because, unlike our conventional medicine, where we can do a study where everyone's going to get the same amount in that one little pill, we can't quite do the same thing with marijuana. But I think it's definitely reasonable to explore if that's something that interests you. Again, it's just really important that we keep that open communication with your medical provider so they know all the things that you're trying. So now let's go to complementary and alternative medicine. These therapies are used by a significant amount of people. I think the amount of people using them are also growing because they do really have great potential to help. And again, we just want to have that open communication, because this goes back to the benefits, risks, and burdens. With conventional medicine, because of our ability to do great clinical trials with them, we can be pretty clear about the benefits. Unfortunately, some medicines really do take some high risks with them. And when we look at complementary and alternative medicine, it's just very difficult to study because you can't roll the therapies that we're going to talk about into a simple pill to do a clinical trial. So while we do have some evidence that seems very promising, we really do need more rigorous clinical trials to determine if they work. We're going to continue to weigh the benefits, risks, and burdens, and overall, most of them really do have low risk and low adverse side effects. So I think, things to keep mindful of, but, we just want to know that there are more things out there that can really help us. So first, these therapies are sort of divided into 4 categories that we'll go over. First, we'll start with the mind-body practices. So there's definitely evidence to use this in addition to other therapies. The evidence that we have really shows that it can improve mood, quality of life, you're coping with the disease, and with the treatment-related side effects. So meditation is really about being aware, being in the moment. I think we probably have the most data about mindfulness-based stress reduction, which was developed by John Kabat-Zinn. And so overall, really safe. It may help with pain, function, sleep, and mood. Some people think meditation has to be something that, takes an hour and they have to study for a long time. Nowadays there's lots of apps where even if it's just a breathing exercise or a progressive relaxation that's only, 2 minutes or 10 minutes, it can be really helpful. Similarly, there's lots of different free things. Oprah and Deepak Chopra usually do their 21 days that they offer free. That's online, that you do at your leisure, whether the morning, afternoon, a break at work, whatever works best for you. And I believe they actually have a new one starting in 2 weeks. So it might be something worthwhile just to get a little taste of meditation to see if it's something that may help you. And then yoga combines physical movement with breath control and meditation. There are many, many types of yoga. So if you've tried it once and maybe it wasn't your thing, it may mean that, a different type of yoga would be a better match with you. And then again, limited data, but some evidence to show that it can help with sleep, stress, and mood. And then acupuncture originated with traditional Chinese medicine. And it's really about regulating the flow of qi, which is the vital energy. And they do this by stimulation of certain points with needles, heat, or pressure. Going back to the wrist, this is one that, of course, we'd want to use caution if we have any bleeding disorders. We'd want to notify the practitioner if, we're on any blood thinners. There is some little limited data about recommendations of people with lung cancer that it can help with surgical pain, nerve pain, and fatigue. No evidence towards colorectal cancer, but again, I think it's because they haven't necessarily done studies to show that. So now let's talk about manipulative and body-based practices, which really focus on moving bones, joints, and soft tissue to affect the circulation, the lymphatic system, and the musculoskeletal system. So massage, also many, many different methods and types. It can be full body, it can be a specific location. Overall, we think it works by increasing blood flow and lymphatic drainage and really decreasing the accumulation of metabolites in our tissues, helping the muscles relax. And people also think it helps change our hormone levels so that it decreases the pain message to our brain, and also helps us sleep. Again, I'm probably going to sound like a broken record for the rest of this talk. Limited data. There were a couple cancer centers that had studies on this. Weak studies, because how if you had a massage or not. But one of the studies did show decrease in pain. This is something, again, if you have a clotting disorder, something your practitioner would want to know about it, or if you're at a risk for fracture. Then chiropractic practice is really about creating an optimum structure to support the nervous system. And there aren't any studies with cancer pain, but many people find it helpful. And then again, if you have a clotting disorder, you're on blood thinners, or you're for a risk of fracture, this would be an important thing to let your practitioner know. And then reflexology is the manual stimulation of the reflex maps that are located on the feet, hands, and outer ears that resemble the human body. And there's, again, no convincing evidence. There's been a few people who actually found it painful, but definitely something that people can explore. And next, we're going to talk about manipulation of energy fields, which is probably one of the more controversial of therapies. So magnetic therapy, which it sounds exactly like it is, the use of magnets. No good studies because, again, it's pretty easy to tell if you have a magnet versus a piece of plastic because of what you will or will not be attracted to. But again, very low risk, so something that may be worthwhile. That being said, if you have a pacemaker or defibrillator, you probably remember your medical provider saying that you do not want magnets close to it. So therapeutic touch. which really revolves around sort of 5 steps, centering, assessing the energy field, unruffling the field, repatterning it, and then recognizing that they've sort of completed this. And there's some studies that say we may be able to decrease pain, increase well-being, and again, really no adverse side effects. Healing touch is very similar to therapeutic touch. They just use a different technique. Reiki talks more about balancing the life force energy and aligning it with the universal energy. It's also described as a spiritual practice. And then again, that has some promising results, but really no adverse effects. I know some cancer centers may be robust to even have a Reiki provider, something to consider. And then Qigong is part of Chinese medicine, and it's really these movements to help strengthen our internal qi through the dynamic life force and really create balance within the life force. And like most of these things, we need more data, but really no adverse effects. And then spiritual healing really refers to prayer and intention. And again, if this is something that makes sense for you, really no adverse side effects. So biologically based therapies, which really talks about herbal medicines, vitamins, minerals, and while they are, quite popular, they can be really problematic. Given the lack of evidence for them and the potential to interact with other medicines, we really have to be careful. We sort of learned this the hard way with St. John's wort, ginkgo biloba, and ginseng, because those can have adverse reactions with some of our anti-cancer therapies, with some of our prescription medicines. So it's really important that you talk with your provider. I know sometimes when people ask me about something that I've never heard of, I may even call my pharmacist. We'll do some more background research because we really want to make sure that we're keeping people safe and not causing new problems. And so, as we wrap up, we need to remember that we all need support, whether we're the patients, whether we're loved ones, whether we're caregivers. It's important to realize that we all need support. And we really want to be able to try and identify where do we find our strength, where do we find that support. And, we're all different, so we're all going to find it in different places. Some people really identify with the medical assistant at their clinic. Other people may have a close connection with a nurse or a social worker or a counselor, a therapist. Other people find support through their faith community. Other people, it might be family or friends. Sometimes people feel like they really need to go to support group because they feel like their, family and friends who do not have the illness, maybe don't fully understand. But I really feel like many things, it really takes a village. So we want to keep that open line of communication of saying, I really need help, or this is really getting hard. And we started this out saying, we really want to keep our good day at the focus. We want to be mindful that what a good day for us is may change. I've met patients when I first meet them, they say it's really important for me that every day I continue my routine and I bike 20 miles. This is my thing, nothing interferes with it, always. And over time, it's changed and they said, I'm sort of over it. The biking's not that important to me anymore. It's really important that I'm able to, share a cup of coffee with my wife every morning. So while what our good day looks like may change, it's still really important that we keep that as our focus and our goal. And your medical providers are excellent at managing pain and really focusing on those goals. But sometimes it can get a little tricky, or maybe they've tried several things and they feel like, man, I've tried all these things, but still you don't feel that great. And so sometimes when that happens, they need to call on some experts. So it might be reasonable, whether you're in the hospital, to consult palliative care, or you're in the clinic to refer you to a palliative care provider, to really get another layer of support of someone who is an expert in managing those symptoms to get you to feel as good as you can. You know, I relate this to, because I'm also a primary care physician, you know, high blood pressure. I manage high blood pressure all the time. Most of the time, you know, we get it done. But sometimes it's like we've added medicines, we've increased them, but somehow it's like no matter what I do, I cannot get that blood pressure controlled. And so that's when I need to get the experts involved. And that's when I'll refer them to cardiology or consult cardiology if we're in the hospital. So I think of palliative care in the same way. If we're having a really hard time managing those symptoms, or if we're having a really hard time of figuring out what does that good day look like, and how are we realistically matching that with, you know, what's medically possible. So I think that's all I have if we want to move to questions.
Great, thank you so much. So while Sharon's getting ready to pull together some of the specific questions that we have from people on the line, Dr. Navarro-Leahy, one of the questions that I have is that if people are specifically dealing out of, you know, active treatment but have specific lingering type pain, that even the surgery is gone and over, you know, that it's not necessarily that it's just kind of a reoccurring issue, is the best means to talk to a primary care doc and go through that avenue? Or when would you actually look at, and how would you get to specialty pain management or care? Or what would you do for kind of, if you're past the acute issues but yet still have pain that it's just difficult managing, what would, in terms of embarking and working with a healthcare provider, what would be a first step?
But I think you're absolutely correct. Just because we are past the surgery or we've completed treatment doesn't mean that necessarily we don't have symptoms that persist. So I think, you know, your relationship with your primary care provider or your oncologist is probably the most long-standing. So it's always great to start with them to say, you know, this is going to continue to be a problem that we need to make sure we're on top of. But I think you're right. If we're trying things and they're still not working, that's when you say, you know, I think we need more help. And that's when I think we need to get other people involved, whether it's, depending on the situation, you know, an interventionalist pain specialist, like when we were talking about, you know, nerve blocks and things like that, or when it's sort of more global and you want a palliative care team to address it, because, you know, managing symptoms is tricky, but, you know, that's why we do have experts who have the extra training to really focus on that. Because certainly, just because we're past treatment or surgery doesn't mean that we necessarily don't have any persistent symptoms.
Thank you, Dr. Navarro-Leahy. This is Sharon, and I have a couple questions that have come in. And to the attendees that are on the line, don't forget you're able to type in some questions. So if anything comes up, feel free to type those in on your computers. So this question is in regards to opioids, and I think you kind of nailed it in talking about, you know, how opioid use is consistently in the news, painting, you know, not a very pretty picture for the usage of it. So what would you tell patients that are, you know, prescribed opioids that are perhaps trying to avoid them based on news or fear of addiction?
And, you know, we see that a lot with our patients because, I mean, I understand, I see the same, you know, news articles, hear the same things on the television. And when we see the misuse and the bad effects of opioids in the news, it's usually because they were initially started inappropriately. So, you know, now the CDC and many health systems are really clear on the guidelines of when they make sense and when they don't. But opioids absolutely have amazing evidence to work so well for cancer pain. And we know if you don't have well-controlled pain, then you can't live your life. I mean, then you're miserable, you can't function. And so it's really making sure that we're managing your pain so that you are able to function and do the things that are important to you. But I really think, if your pain is this high, we're going to match it with pain medicine. So it's not going to become a problem. Addiction isn't a problem. You're not going to overuse it. We're really matching it appropriately. And if pain gets worse over time, then again, we'll increase the medicine and match it. We're not there, to give too much. And like some people like to say, snow people, we don't want to give too little, where you're like, I'm taking this medicine, but here I am still in pain. It's really finding that perfect balance. And also being ready to change it, because oftentimes we do, because things change, your pain changes. The cancer can move somewhere else and cause a different pain. But rest assured that we have so many studies that prove that opioids are indicated and very effective for cancer pain. And know that your medical providers are well trained in doing it appropriately.
So kind of switching gears to the complementary therapies that you had mentioned. If a doctor is not open to discussing these suggestions, how might a patient bring it up? How would you find a second opinion for pain management to really discuss in depth some of these complementary approaches?
That's a really good question, because I can imagine it being really hard if you feel like your provider's against it or sort of doors closed. I think sometimes just saying, I'm really worried about my pain or whatever other symptom that may be bothering you, and be like, I really need to explore all things that may help me. I've heard good things about XYZ, so whether you're asking about massage or reflexology, what are your thoughts? And I realize that you may get sort of a closed door on it of like, no, I really want to give you this medicine or this medicine. And some of the more comprehensive cancer centers might also be affiliated with integrative medicine centers, because sometimes doctors will give you the closed door just because they don't know a lot about it. So sometimes pursuing those other avenues of people who have more experience with it, so that you might feel more comfortable to refer out. And then again, maybe your primary care doctor versus your oncologist, one of them might be more open to it, or might be more willing to sort of discuss it with you. Because ideally, I think, having open conversations is really better for everyone, because we want to, make sure we know what people are taking and what people are trying, again, to keep people safe. But yeah, I would just say, I'm really worried about my pain, and I'd really like to minimize the pills I'm taking because I'm taking so many. I've been thinking about exploring massage or Reiki. Do you have any thoughts about that? Or, do you think you would refer me to an acupuncturist? Things like that.
Great, thank you. So we have a question that came in about CBD oil to manage neuropathy. Have you heard anything about this, or whether or not it, I know there's a lot of rules and regulations around medical marijuana, but we have a question as it relates to neuropathy specific, if you've heard of anything.
I do think many of our cancer patients talk more favorably about using things that are CBD only, or at least more CBD strong than having the THC in them. And so I think that's why it's great if you can go to a reputable dispensary. I think there's a couple European companies, because it's CBD, and CBD is actually not illegal because it's a botanical, oils that people will use for pain and neuropathy. Again, we don't have great studies for it, but I think, especially CBD only is really great because it has less side effects than things that have THC. So I do think it's a reasonable thing to explore.
Great. Just a couple more. Let's see. I guess we'll stick on to this complementary thread here. So online, there are a lot of websites that discuss alternative therapies. How do you know what to try and what not to try?
That's a great question. And so that's when, it would be great if your primary care provider or your oncologist were open to it, because there are sort of guidelines and centers that we look to just to look at evidence-based things. And then I think, also looking at sort of what do we think are the risks associated with it. And especially depending on, where you are with the disease process, certain things, like a full body massage would be really like painful for some people, or depending on, if they're healing for something. And so then sort of the Reiki, where there's not actually physical touch and it's more of the energy fields, that might make more sense for someone. But really trying to think about, what makes the most sense for you to try. Because again, we don't want things to cause you more pain, more distress or anything like that. I do admit it is a little difficult when you're, on the internet to sort of sift through, what's real, what's not, and not get caught up in things that don't necessarily make a whole lot of sense.
Right. So I guess coming back to talking to your provider to make sure what you're doing isn't going to have severe negative side effects, or also interfere with your other treatments. So that's a good point to drive home. We have one final question here. I think it's one more. Oh, looks like we have a couple more. Are there any apps that you know of or tools that can help folks stay on top of their pill reminders and medical management?
Oh, wow. I don't specifically know of any apps, but there must be, because that's a great idea. I mean, I think we're still a little old school where we still use like pill boxes. But again, still not great if you forget to go to the pill box and actually take them. But I'll have to look into it, because I think nowadays, I know people will even just set like a daily reminder if there's like a 1 time a day pill. But of course, when we're undergoing cancer treatment, usually our pill regimen is a lot more complex than that. So that is a question, but I'll have to look into that, because that would be a great app to have.
Sure, we'll follow up also at Fight CRC, so we can make sure that the attendees and listeners of the webinar can find some of those apps. And for our final question, can you comment on neuropathy in general, and what would be the most common management regimen to address neuropathy?
So neuropathy is really common. So whether someone has bad diabetes and has had neuropathy, some of our anti-cancer therapies can cause neuropathy. So lots of things can get us to the point of neuropathy. And so I think, oftentimes, again, depending on other symptoms you're having, people will start with one of the tricyclic antidepressants, amitriptyline, nortriptyline. Amitriptyline's been around a long time. Nortriptyline's a little bit newer and has less side effects, but really simple dosing that can help a lot. And I think sort of people have different preference between the antidepressants versus the anticonvulsants. I mean, gabapentin is a mainstay that we start many people who have neuropathy on. And gabapentin is an interesting medicine because everyone's a little different about finding the dose that makes the most sense for them. I may have a patient that only takes 100 milligrams at bedtime. I may have someone else who takes, 1,000 milligrams 3 times a day. And know that all of those doses are safe. It's just a matter of what makes the most sense. And so sometimes, people get a little frustrated as you sort of tinker with finding the dose that makes the most sense. But of course, no one wants to take extra medicine if you don't need it. And then nowadays, I'm sure people have seen commercials for pregabalin, which is sort of if people are not responding to gabapentin, we sort of have a stepwise response. But I would say our, two major go-tos to start with would be gabapentin or one of the tricyclic antidepressants like amitriptyline, nortriptyline. I mean, reasonable to start with any of the other ones, but those are probably sort of like first line that a physician would start with.
Thank you so much. And I think you also brought up a really great point that you also mentioned during the webinar presentation, is that management of pain is going to be different for everybody. And so sometimes you might need to switch it up or reduce or do a little more and work closely with your doctor to figure out what's going to work for you and be open to changing. Is that correct?
That's absolutely correct. And then, like we talked about how you describe your pain, usually people don't necessarily just have one kind of pain. So we're trying to attack pain from different sides to really manage it best. So, sometimes we can get it done with one medicine. Sometimes we really have to do it with a couple, attacking from different sides. And for everyone, it's going to be different. So, I mean, you as the patient, you're the center of it all, and your provider is going to figure out what makes the most sense for you. And it's not, cut and dry.
Yeah. Well, that's it for today. Thank you so much, Dr. Navarro-Leahy. We really appreciate your presentation and such great information. And to all the attendees, thank you for tuning in. The webinar will be housed on our website, so if you want to refer back to it, you are more than welcome to. And thank you to Andy Dwyer and Michael Sola for all your help with the webinar today. And again, thank you, Dr. Navarro-Leahy. We really appreciate all the work that you do.
Well, thank you so much for having me. It was great to speak with all of you today.
Bye, everyone.